in today's episode, we're going to talk about how much progesterone is needed to protect the uterus. I'm Dr. Davidson from Progress Your Health.
And I'm Dr. Mackey from Progress Your Health. So this got started, probably about a month ago. Had a patient that was using oral progesterone, 100 milligrams, did not tolerate it, did not feel very good, went to 75 milligrams, instant release progesterone, oral, and still didn't really feel that great. Then the discussion came into switching it to roughly 80, 100 milligrams of progesterone cream. And then that's sort of where we are right now.
So, we've been doing these hormone replacement, doing hormones, working with women for 20 years. And it's always been kind of our sort of go-to is if you have a uterus and you're taking estrogen therapy, like I assume this patient is taking estrogen therapy, and you need to protect that uterine lining, and an oral progesterone, and pretty much if you talk to pretty much a lot of, especially doctors that have been doing hormone replacement, they will tell you that they want to use an oral progesterone to not let the lining of the uterus thicken up. And I have seen that happen before in many different cases that we can definitely get into. So it's a new kind of twist here where, does the progesterone cream protect the uterine lining if somebody is on estrogen?
Yeah, right. So this is granted, hormones themselves, their use of hormones is sort of controversial enough, right? Some doctors believe in it. You and I are of the ilk that believes in hormone replacement. Conventionally minded physicians might not, although a lot of them do. But there are still, we run into it all the time. There are still some opinions about hormones are dangerous, hormones cause cancer, hormones, you should stay away from them. We certainly don't align with that. We've seen amazing benefit for women and men using hormone replacement therapy. But a controversy within a controversy is, do you need, in order to protect the uterus, do you need oral progesterone, or can you use progesterone cream?
Maybe I'm still a little old school. I know that there are some articles, we've talked to some other practitioners about how their use of doing progesterone cream with estrogen therapy has been fine. I really think it does come down to dosing. If a female's using quite a bit of estradiol, then no, I really don't feel like a progesterone cream is going to protect that lining. And even I've had some women that are taking 100 milligrams, like you said, the 100 milligrams of progesterone capsule orally, that even that isn't enough to be able to keep that lining from getting thick, because every female's different. So just to kind of back up a little bit, let's say there's someone that had really heavy periods when they were younger. They were, really heavy. Day one, especially day two, was like hemorrhaging. So they had super heavy periods. And then once they come into menopause, I always feel like their endometrial lining is very sensitive to estrogen. So if you do give them estrogen, they're going to have a thickened lining. So they need to go definitely on some kind of oral progesterone or a little bit higher to protect that lining. Now, let's say you have another female that said, I never really had heavy periods. We hate her. I could just use a panty liner and just get away with it. It was no big deal, never had heavy periods. Then that person right there, giving them estrogen, it may not cause their lining of their uterus to thicken up as much, and they could get away with maybe a lower dose of progesterone. But the thing about hormone replacement is, yes, we want to get you feeling better. We want to work on the anti-aging. We want to work on the hair, the mood, the energy, everything, the libido, but at the same time, we want to keep someone safe.
Right.
So I know with this one particular patient that you felt, safety was first, that she probably wasn't a candidate to take oral, or to take estrogen therapy plus just a transdermal progesterone.
Well, this sort of got more complicated because then one of the pharmacies that we work with was sort of, posing this exact question about the oral progesterone versus the cream progesterone. And you and I, like I said, have always been under the mind that you use oral in static dosing to prevent the uterine lining from growing. Where the document, the studies, the research, everything, the literature supports that. Progestins, so basically commercially available progesterone, which is kind of sometimes categorized as the same thing, that does a very good job of protecting uterus. But you and I are not going to use progestins, for any reason. We're going to use bioidentical progesterone, and it's always been the idea that oral is the way to go. Now, to make this situation a little more complicated, this patient had been doing, so the two basic schools of thought with hormone replacements, you have static dosing, which is what most women are doing.
That's the same hormone. You take the same dose every single day, and you're not. If you have a uterus, you do not bleed. There is no bleeding. That lining stays real thin.
Number one rule: no bleeding in static dosing. If there's bleeding, then you have to change something. Either increase progesterone, decrease estrogen, stop estrogen. We've done a couple of episodes recently where women in perimenopause, they're still getting their own period and they're being put on estrogen. That is not necessarily always the best idea. It depends on the woman
and the dose,
and the dose. And in this situation, it depends on the woman and the dose. But our belief has always been progesterone capsule is going to be the safer route.
But you said and that's with the static dosing.
With the static dosing.
Now the other type of therapy you're saying.
Oh, I'm sorry. Yeah. So I'm a little distracted there. So static dosing is one way. Probably 98% of women are going to be doing some form of static dosing. She was doing rhythmic dosing, didn't tolerate the rhythmic dosing very well, which, it's not for everyone. A lot of women do very well on it. And the ones that do well, they know they do really well. And the ones that don't do well, which is the minority, they also know they don't do very well. So it's not necessarily a one size fits all. But in that instance, rhythmic dosing, you are actually intentionally trying to recreate the menstrual cycle. So for a woman that has her uterus, no matter what her age is, she is going to get a period roughly every 28 days. So two completely different schools of thought or philosophies about dosing hormones. They all have their place, right? If you're not interested in getting a period, then rhythmic dosing is not an option. Then you default back to static dosing. So the idea is you use cream progesterone and rhythmic dosing to encourage a period.
And cream estrogen as well.
And cream estrogen as well.
All transdermal creams.
Yeah, all transdermal cream and rhythmic dosing. And then in static dosing, you use a transdermal estrogen, but with a oral progesterone.
And then with the rhythmic dosing, you're changing you're changing the dosage every few days to mimic a 28-day, perfect female cycle, where in the static dosing, hence static, it's exactly the same dose every single day.
Now, we're going to probably do some more about rhythmic dosing just to clarify, because it is, it's not complicated, but we are intentionally, for a woman in menopause that has not had her own period for, a year, 6 months, a year, a couple of years, 5 years, we are intentionally trying to recreate that menstrual cycle.
And that, so as we're talking about, how much progesterone is needed to protect the uterus. When you're doing a rhythmic dosing, so you're changing the doses, you are intentionally thickening up that endometrial lining and then having a slough of that lining, hence a bleed, that is protective. So that is, even though somebody is having a period, still doing it in that rhythmic fashion where you're changing the hormones, that is protective to the uterine lining.
Right. Yeah. Like I said, this is kind of like a little new thing for you and I to chew on a little bit, because we've always been doing it one way.
That's the rhythmic dosing. And then, like I said, with the static dosing, there's not supposed to be any thickening of that lining.
No, none whatsoever.
Any bleeding.
Yeah, that's, like you said, number one thing first is safety first. Static dosing, bleeding is not an option, where the other one, it's encouraged.
Now, hey, there's so many different types of progesterone. There's oral, there's gels, there's creams, there's troches. But, this is maybe something we should have mentioned at the beginning of this episode, is why would somebody not tolerate a progesterone 100 milligram capsule, or not tolerate progesterone orally? What would be the reasoning behind that? What would they feel if they took it?
Yeah. As well as I do.
Because,
you're preaching. It's a rhetorical question.
I take progesterone, oral progesterone. I take, a sustained release 100 milligram progesterone capsule at night, because that does, progesterone can kind of relax you a little bit. I do a sustained release because it stays in my system throughout the night, because I'm notorious for waking up in the middle of the night and just staring at the ceiling. I've done that since I was a child. But a lot of women, especially in perimenopause and menopause, they will wake up in the middle of the night, so they need that, having that sustained release. Now, you had mentioned about instant release. So some women that have trouble falling asleep, they put their head on the pillow and they can't fall asleep. An instant release is really nice because it can help them fall asleep quicker, and then it comes out of their system a little bit, earlier in the night. But maybe those women don't have issues with staying asleep. It's more about falling asleep. Now, this patient in particular, and we've run into other women like this, and we've got lots of questions from listeners and readers about this same exact situation, that they take an oral progesterone at night, but they're still groggy and tired the next day. So that could be the reason why this one patient or other people are saying, I can't tolerate oral progesterone because I'm tired and I don't feel right the next day.
Yeah, it makes them feel depressed, makes them feel tired. For some, it can make them feel anxious, right? They almost get like a stimulating effect from it.
Yeah, not all those symptoms all at once. Some people might have a little fatigue or, everybody's different.
Like it's one or the other. Usually you're going to be depressed and groggy the following morning, or you're going to be more on the anxious side.
Now, that's not everybody. That's a smaller percentage that we've run into. Like myself, the majority, I wake up at 4:45 because that's a good time for me to wake up, between 4:45 and 5:30, and I'm fine. I don't feel groggy the next day, but there is a percentage of women that needs to, be addressed, that do wake up feeling tired, that do feel groggy. And I've had some women tell me that they feel groggy up until, 1 p.m.
Right.
That's pretty much, a big part of the day. So I can understand the idea about, hey, let's go to a transdermal, because have you ever had a transdermal create sleepiness or being tired?
I mean, we don't use transdermal in the context of improving. Now,
I use a lot of transdermal actually in women that are menstruating and they don't need the estrogen, so they might just do a transdermal cream. I have found that some women, the transdermal cream can make them tired or more relaxed, not necessarily sleepy, but it can really help in anxiety. Yeah. So the women that I have doing the transdermal cream in the morning tends to help them relax a little bit. But some of them, if they get sleepy, then we just have to do the transdermal cream a different time of the day. Yeah. Same with the oral. Pretty much, I don't have anybody taking oral progesterone in the morning because it does kind of make you a little too relaxed.
Yeah, so if you're going to work or something, or having to get a bunch of things done, you take it, when you wake up in the morning, and now you're groggy for the first half of the day.
And I have had women that accidentally took their progesterone capsule instead of their thyroid. They just mix them up because maybe they were the same color capsule.
Or they just thought they're supposed to take it in the morning, and all of a sudden, here they are. Am I supposed
I've done that before.
I'm so groggy. What's going on right now?
It happens. The other day, I actually took my thyroid capsule at night thinking it was my progesterone, and they're totally different colors. I don't know. It's just this. But it was fine. It's fine. Yeah. But I will say, taking that oral progesterone in the morning, it's not going to make you fall down and stumble or wreck your car or anything.
You're not drugged or nothing. You can still operate heavy machinery if you had to.
You just feel because progesterone is so nice and relaxing. It's like, oh, I'm just so relaxed. I'm just going to stay right here instead of getting all the things I need to get done during the day. So that's why it's nice to take at night to help you relax so you can fall asleep, turn off the motor mind. But in other cases, like this patient you were talking about, it was making her feel really tired and depressed during the day. So I can see where, she doesn't.
And that was taking it from the night before, and it was kind of lingering over into, which is why we just changed it from an instant release to a sustained to an instant. So it was lingering on the following day.
Still, even in that instant, that a couple of things I would say with that is that person, like you said, safety. It's about, working on that safety. Like we've been doing hormones for 20 years. I don't know how comfortable I would be in a certain patient giving them a transdermal cream, not knowing what could possibly happen.
Yeah, right. Meaning that the transdermal cream would not be enough, even at a higher dosage, let's say 200 milligrams or something. At a higher dosage, would that be enough to protect the uterus long term?
And I know other practitioners say it does. Pharmacists are like the smartest people in the world. They say that it can. It's just I still feel like I said with a particular patient, if this patient was having heavier periods, maybe was bleeding too much when she was on that rhythmic dosing, that her endometrial lining is very sensitive to estrogen. Right. That not having something like the oral, it may not protect her uterus, and then she could get spotting, or you might want to, really complicate it and make her go get transvaginal ultrasounds every few months.
And I know some doctors that do hormone replacement require a transvaginal ultrasound every year, which is, not a bad idea. At least you have a baseline of sort of where it is, and in that situation, that would be the thing to do is if you are going to do a progesterone cream because you can't tolerate the oral, would be to do periodic transvaginal ultrasounds to make sure that lining is not getting any thicker. Mm-hmm. Now, if you have bleeding right away, within the first month, the first few weeks, the first 3 months, that sort of tells you what you need to know. The bleeding is going to be your answer that something there has to change. Now, I don't even know, like you said, there's so many things that go into that, the estrogen, the type of estrogen, the dose of estrogen, the woman's sort of phenotype, like how she expresses her response to estrogen. All those things are going to be taken into consideration, whether or not she can safely use progesterone cream over time. I don't think it's an exact science. You can just replace progesterone capsules for progesterone cream and call it good. I don't think you can really do that.
No, and I know, with blood work, like it would be interesting to see like what this patient's blood levels look like of progesterone the next morning. Because ideally, if you're taking an oral capsule, 100 milligrams when you're on hormone replacement, 100 milligrams is basically like a size medium. That's the most common dose. I think I can think of maybe a couple of people off the top of my head that I have a little bit lower than that. Mm-hmm. But even the 75 would have been pushing it on somebody with, like you said, that phenotype that's very sensitive to estrogen. 75 might be too low. 100 could be too low. But let's say you did blood work after they took that progesterone, that oral progesterone the night before. It stays in your system. The levels in the morning really should be pretty on the lower end, right around 2.5. Not as high as 4, definitely not below 1. But when you keep it between 2 and 4 in that morning blood draw, that's showing that that's pretty protective of the uterus. But let's say I have a patient that took her oral progesterone, sustained release, 100 milligrams that night before we do the blood work in the morning, and her progesterone's at 14. I know that progesterone is lingering in her system for that morning, and that's why she'll say, oh yeah, I am kind of tired in the morning, or it takes me a while to percolate and get up. So then I know, well, I'll switch that sustained release to an instant release, or I'll even have them take it a little bit earlier in the evening, like, hey, take it right at dinner time. Take it at 7 o'clock at night instead of 11 o'clock at night. So you can change that. So that 100 milligrams, because I do feel like I said, 100 milligrams is a size medium. That's the go-to. But I do have, I do say, protecting that uterus. I have some women on 125, 150, 200. I don't really have many women over 200. It seems like 200. More than that, it really depends on the person and what we're working with. That might be more anxiety.
Yeah, right. Yeah. It sort of caps out at 200. Yeah, I mean, you could go up to 250 if you needed to. I think we've had a few over the years where we've gone above 200. But usually once you go beyond 200, if 200 doesn't work, going beyond that still isn't going to work that well. Now here's the interesting part. So all the research and all the literature supports the use of oral progesterone for protecting the uterine lining.
Because it's checking the serum blood levels also. Because that was one thing about the cream, is the cream, when it's the serum blood levels aren't reflecting the cream. Apparently, what we've been looking into with our research, that it actually, instead of going through the circulatory system, it's going through the lymphatic system. So you can't really check someone's progesterone cream and say, oh, look, your levels are so low in the blood, we have to change them. Mm-hmm. That's where maybe perhaps saliva or urine might be a better way of testing.
Looking at progesterone levels, right? But the literature supports the use of oral progesterone, but does not support. There's really no. This is the discussion we had at the pharmacy. There is no research to support the use of transdermal progesterone. And I thought about that for a second. I'm like wondering why there's no studies. But if you think about it, there is no commercial available drug, pharmaceutical drug for progesterone. Now, progesterone, of course, is a prescription, FDA approved, but it all comes from compounding pharmacies.
The capsules. Is the transdermal FDA approved?
Of course it is, yeah, because it comes from the pharmacy. Mm-hmm. Whether they put it in a capsule or a cream, it's the same thing. It comes from the same place. They're just, they're capsulizing one or they're putting in a cream. The recipe is just a little different on how the compounding pharmacy makes it, but it's still USP, FDA approved progesterone. But there is no commercially available progesterone, just prometrium, and then all the other progestins, which there's quite a few of those. That's why I'm sure that there's no research to support it, because the research is only geared towards the oral route, not the transdermal route.
Exactly. So that's with the hormone replacement. Now, what about females that are, like I said, menstruating? They're making their own estrogen. They're not taking estrogen therapy. I would say, the progesterone really depends on the person. I have a lot of women on oral progesterone that aren't actually needing the estrogen therapy, and I feel like that's protective to the uterus.
Or can't take it because they're menstruating on their own.
Yeah, they couldn't. Like women that have really heavy periods, their progesterone is showing up lower. They have more estrogen dominance. Giving them an oral progesterone, I find that it does thin the lining of the uterus, so then their periods aren't so heavy. It takes a few months, because every month it has to, create a little bit more thinning of that lining. So that's one way I've used for a long time is heavy periods, estrogen dominance, give them some progesterone. It thins the lining of the uterus. Their periods are less heavy. They're less apt to become anemic. So their iron levels are fine. But when I've done that with cream, I haven't noticed that their periods get lighter.
Right. Yeah. It doesn't seem like it has enough.
But maybe it's the dosage I'm using. Maybe it's different with menopausal women doing HRT than it is with a menstruating, female that's cycling. But I haven't noticed. That's why I would always switch to oral capsules to try to, keep those periods not so heavy, because I found the cream didn't really do much effectiveness for that part. It had other things, for the mood, for the hair, for the skin, but not really for the heavy bleeding of a period.
Sure. And in that context, you could extrapolate as well. If it does not, and that's what we use progesterone in a menstruating woman, use progesterone all the time, safe to do. You can use oral, you can use cream, you can use any menstruating woman. You can use progesterone pretty much at any point, depending on what the situation is. You can't do that with estrogen necessarily, menstruating women. That's more for menopause. So you could assume there that if you are using progesterone cream to exert that, that kind of, PMS reduction effect, meaning less PMS symptoms, less heavy bleeding, and it doesn't really do that, then we could also assume that the same thing is going to happen in a menopausal woman. If she still has a uterus and she's on estrogen therapy, we could assume that the progesterone isn't going to really quite protect it as well as the oral progesterone might.
That was just my thought, just in clinical
from observation.
In clinical practice.
I
don't have any studies that show anything like that because I haven't done any studies on that. But just from clinical practice, I've noticed that. There's every woman is different. I think in terms of, like I said, a progesterone 100 milligram oral capsule is like a size medium, but what I find is the progesterone, which I love the compounding pharmacies and doing the bioidentical progesterone. I think you can really keep the fillers nice and clean. They don't have to have peanut oil in there. It doesn't have any soy or any kind of weird excipients. But the Prometrium, I find, it does and it only comes in two strengths, 100 and 200. And I have a few women that we do Prometrium with because they've been on it, or it just happened to work really well for them, or it was available for them. Is I do find that the 100 and the 200 they're instant release. So it doesn't do as much effectiveness for helping somebody stay asleep, but it does a really good effect, I find, on that uterus, where I almost feel like the Prometrium just seems stronger.
Yeah. Which is also potentially where some more of those side effects can come from too. The things that women experience using oral progesterone that they don't want, seems like it can be exacerbated by the Prometrium versus using a micronized, bioidentical progesterone.
Because
which technically Prometrium is bioidentical progesterone.
Yeah, it is. It just has a bunch of fillers and it's different. But I have found that with the Prometrium, when I've done the blood draw the next morning, that sometimes, even though it's supposed to be instant release, so some women might not get the effectiveness of staying asleep, but other women, like, that are sensitive to progesterone, I do find that their blood levels are a little bit higher, hence why they're groggy. So you're trying to find this balance between, safety, because we want to protect the uterus, we want to protect, all the hormonal tissue, and then at the same time, we want people to feel good, not feel tired and depressed the next day or anxious, depending on what their symptom is with that progesterone.
Sure. So, really, it comes down from a practitioner standpoint. It's like I said, it's all about safety. When you look at the literature, it's lopsided in one direction, supporting the use of oral progesterone, which is what we've always sort of believed and have done. And like I said, there's a lot of factors that go into that. The woman, the dosing of the estrogen, all those things. But now this progesterone idea is more, in some ways, more anecdotal, right? It's more on the practitioner level, which at the end of the day, when you have, and which is what the pharmacy was sort of relaying, that when you have, hundreds and thousands of practitioners and patients that seem to be doing well and tolerating well, then it could be for those women that don't tolerate progesterone capsules. It could be, right? We're not endorsing it and not saying that it's a great idea, because there's a lot of things that need to be taken into consideration, but you could potentially, at least in theory, use progesterone cream, maybe.
Possibly, there's a possibility there. I'm not sure I want to experiment on my patients to do that, but just moving forward, talking to more practitioners, talking to colleagues, talking to pharmacists, kind of talking to, other patients even, to see if it could be a possibility. Because because I can understand your patient. I have had other patients, and we've had other listeners too, that say it just makes them so anxious. It makes them so depressed. It makes them so tired. What are they going to do? Definitely don't take your estrogen cream without the progesterone if you have a uterus.
Yeah, you can't, just because you can't tolerate progesterone capsules, you cannot take your estrogen on its own.
Because eventually that lining will get thick no matter what your body type or what your response is to estrogen. Eventually it will catch up with you. But I do think
it may take several weeks. It could even take several months, but eventually that's going to potentially turn into a problem.
Yeah, you know, with somebody that is having a problem with it, they could switch to the rhythmic dosing where they're changing the estradiol and they're changing the progesterone throughout that 28-day cycle. They're going to get a period, but at least that would be safer. I would say so for anybody that's having trouble and they're taking estrogen, they're taking hormone replacement, and they're having trouble with the oral progesterone, that I would definitely consider going to the rhythmic dosing route for that safety. And they probably feel good on it.
I'm sure you've had that issue. I know I've had that issue a couple of times trying to do static dosing, and there was always some bleeding that was occurring. And it just kept happening and happening and happening. You can't let that happen over time for too long. So like, all right, as a way to regiment the bleeding, make the bleeding predictable, right? So it happens every 25 to 28 days as opposed to randomly. The strategy was to go from static dosing to rhythmic dosing. So now you're intentionally growing that lining. You're building it up on purpose, and then the woman's sloughing it off. That alone is what sort of makes it safe to do over time.
Yeah, because it's exactly what would happen in a menstruating female cycle, right? When they have that 28-day cycle. Nobody has a perfect 28-day cycle, but that first, day 1 to day 12, that estrogen is coming up. Then you have that ovulation on day 14. Because in an ovulating, menstruating female, you only make progesterone day 14 to day 28 till your period. And when you do blood work on a female with that, if you do their blood work on a menstruating, cycling female before day 14, usually their progesterone is low, but that is because it's supposed to be low. But then if you check them off after ovulation, usually right around day 21, you can see some levels up, 13, 14, 16, 11. Those are beautiful numbers. But then let's say in a menstruating female, you check them on day 21 and their progesterone's 3. Then, they're not really making a lot of progesterone and they're making a lot of estrogen.
Which in a sense is sort of the definition of perimenopause, right? Perimenopause is that first initial drop in progesterone. Once the woman stops ovulating, progesterone production drops way off. So they have this lopsided balance between estrogen and progesterone. So of course that woman's going to benefit by giving her some progesterone in either form, the oral or the progesterone cream. But like I said, it just gets really complicated. I don't think that I guess it goes both ways. Oral progesterone doesn't work for every woman. The cream progesterone does not work for every woman. This is where the practitioner sort of has to decide which one is the best tool to use given the individuality of that woman. That's why hormone replacement is not a cookie cutter approach. You can't just give, you can't have 3 doses and every woman's going to be able to respond to those doses equally. It just doesn't work that way.
No, it doesn't. And like you were saying, when it comes to the progesterone dose to protect the uterine lining, it depends on the type of estrogen they're taking. If a woman's on an estradiol patch, oh, no way, no transdermal cream whatsoever. Even the oral capsule, you might have to go a little higher than 100 milligrams if you're doing the micronized compounded progesterone. And even with prometrium, you'd probably go up to 200 milligrams if they're on a patch, depending on what the dose of the patch. But estradiol straight is pretty strong. If someone's on a low dose of Biest, there you could maybe change that progesterone dose. But I'm still. Here it is, 2024. Okay, we're dating it, July of 2024. I myself don't feel comfortable using transdermal progesterone with someone that's taking estrogen therapy if they have a uterus. I still don't feel. It would have to be a case-by-case basis. I'd have to make sure that female really worked with me, not here's a prescription and then I don't see her for a while, maybe do some transvaginal ultrasounds to make sure that lining's not getting thick. That, it would have to definitely be a case-by-case basis.
Sure.
Until we know more,
in some ways, when you step back a little bit and you're talking science, you're talking medicine, you're talking physiology, this is where, this is how things move along. It's not that it's always one way. We're always learning. That's why it's really the practice of medicine. Here we are, been doing this for 20 years, and this idea, which has come up over and over and over, this idea between, and we've gotten lots of questions over the years. Can I use cream versus capsules versus creams? Which one's better? And you really, at the end of the day, you'd have to say it depends. You can't say one is better than the other. Now, we gravitate more in general towards progesterone capsules, but there is that segment of the population. What would you say? Of all of our patients we've had over the years, what percentage would you say that does not tolerate oral progesterone?
In my clinical practice, it's not many. I would say probably more like 10 to 15%.
You think it's that much?
5
to 10? 5 to 10?
But usually that don't, but then we have to work our way into getting used to it. Like a patient I just had the other day, she's more perimenopausal and she was very much estrogen dominant, so we actually worked on that. But we had to start her at 25 milligrams of progesterone and work over the last 4 months to get her up to 100, not because we're trying to protect the uterus, we're really trying to balance out her estrogen dominance. And she feels so much better once we've been able to work up to that 100 milligrams of progesterone.
But you did it gradually.
Gradually, she's on an instant release. She said her depression has gone away, her anxiety has gone away, but she's not quite as motivated that she used to be. And I said, well, maybe a part of that motivation that she had was backed by anxiety. You know, anxiety for some of us, and I'll say me too, will get you out of bed. It will get you doing things. It will get you on time. Of course, if it's too crazy, then, you know, you don't do anything and you spiral. But I was saying, you know, maybe it's okay to be relaxed. You don't have to go. You don't have to get it done right away, that it will get done.
But now if you are fueled by anxiety, that eventually is going to sort of backfire.
Her adrenals have, you know, we've been working on her adrenals because she definitely has a lot of, adrenal insufficiency going on. So there's that case where, you know, we had to work our way up. Same with somebody that's on estrogen. I might say, you know what? You do need estrogen therapy because you're in menopause and you're having the symptoms, but let's go real low while we get you used to your progesterone first. And once they're used to that progesterone first, then we can change up that estrogen and raise it up.
Sure.
So I really, I do feel like there is that percentage, but you can work with them. It's just not like, oh, I took it once, or I took it for a week, I felt terrible, I'm never going to take it again. It's like, hey, let's figure out a system, because I'm always trying to problem solve. And as humans, we're very resilient. Our bodies are very resilient. It can adapt to anything. I mean, look at our, unfortunately in our country, it can adapt to a lot of things.
Yeah.
But with chemicals and toxins and environment and foods and, all that, the body can adapt. So I do feel like you can work your way into letting it accept it. It's like, jumping into, cold, you do the cold plunges. I tried to do like the cold shower this morning. I could not do it. I'm just so bad at it. I know it's good for you, but if you had it, but so what I'll do is I'll go warm or hot, warm, then cold, and then because I can't go from hot to cold. Everybody's different.
It's really challenging in the wintertime, but I like a really hot shower. We're not even doing an actual cold plunge because you're right. That's a big deal. I've been in lots of cold lakes and rivers, so I know what that feels like. But I like a really hot shower. You take like a lukewarm shower.
I feel like it's pretty warm.
You couldn't even stand in the shower that I take. I take a nice hot shower, but then I turn it all the way to cold. And you're right. It's it gets you start breathing heavier, and
so it's kind of like the progesterone. Maybe before you start with the estrogen on somebody that's sensitive to the progesterone, instead of jumping up to 100. Hold off on that estrogen for a little bit and work your way up till they get used to that 100, and then add in the estrogen.
Sure. Yeah. Now, most women, though, when we're talking static dosing, which is the predominant way of dosing hormones, oral progesterone is very well tolerated. Across the board.
I would say so. But
out of 100 women,
different.
Out of 100 women, 90+% of them are going to be able to tolerate oral progesterone. We've been doing it for years. It's sort of like the bread and butter. There's this small segment that we've run into over the years, and this one recently
especially with our listeners and readers, we've gotten a lot of questions about our community or people that are listening to us that are saying that progesterone, they don't do well on it.
Yeah, right. Well, now
probably because they don't have a lot of answers.
If you take it from our practice at a certain number of people over a certain amount of time, and you extrapolate that to the entire country, we're probably still talking millions of women that don't tolerate oral progesterone. It's really hard when you're doing a YouTube channel or a podcast and the numbers that you're able to impact. It's really hard to comprehend. Our YouTube channel is already brand new. We only have a few videos up there, but one video, our first video, got like 2,600 views. That's sort of nuts to think about. Now, granted, that's not as many as some channels. Some channels, they're getting six figures, they're getting 500,000 views, 1 million views. Those numbers are mind-boggling. That you don't need to have a broadcast network television show. You're basically on your phone, and you're able to reach these kind of people. It's pretty amazing.
And that's why we're doing this. So because all that we've learned in, the last 20 years, I love working one-on-one with patients, but it's just, one-to-one. It's really neat that, if somebody's listening or they are watching us, that they're interested in what we have to say. If I have something to teach you, I'm so glad about that. I'm grateful.
Yeah, I think that it makes it both a podcast, YouTube, social media, which you and I are a little bit late to the party, right? We're kind of doing this a little bit, later than we probably should have. We didn't maybe understand exactly all those things, whatever. At least we're here now and we're enjoying it. It's really actually very fun. It's, it's a little nerve-wracking at first, but once you sit down and do it and you've got a few videos up there, it actually sort of becomes fun. And doing it with you, I wouldn't rather talk to anybody else but you anyway. So this makes it even better. So.
Ditto.
Yeah.
Likewise.
Well, sometimes you'd rather talk to other people than me, but at least on the podcast, anyways, we're making it work. So, like I said, this is a to be determined conversation. Oral progesterone versus cream progesterone. Does it protect the uterus? I'd say it can in both instances, and I'd say it can't in both instances. We lean more to the progesterone capsules. I think there is potentially an opportunity for some women to try cream progesterone, but I think that one takes a little bit more scrutiny or a little bit more cautiousness just in general. Your final closing thoughts?
I totally agree with you. I do think, like you said, the different doses of progesterone can vary on each individual. Cream versus capsule, like I said, I'm still more hesitant to jump into the cream aspect. It's trying to work with somebody so they could tolerate the oral, working that way. But I do think ultimately, I hope we answered the question. I hope we kind of picked it apart, didn't we?
The question was, or the title is, how much progesterone do you need to...
light went off. Oh, that's weird.
Oh, that's weird.
I guess it's time to wrap up, huh?
Yeah, I guess it's time to wrap up. We didn't have it plugged in long enough.
Lights are going down.
That's really embarrassing that the light just turned off. I don't know what we're going to do about that. I got to talk to the production crew. Our set's falling apart.
It's not the lights, it's the information.
Yeah. Well, no, it looked really cool. Now it turned off. All right, so we'll wrap this one up. Until next time, I'm Dr. Mackey.
I'm Dr. Davidson.
Take care. Bye-bye.